So there has been a lot of controversy concerning the COVID-19 vaccines, the COVID-19 virus itself, and the new variant that has come up. So I decided to make this video to educate each and every one of us, medical professionals and non-medical professionals included in this video. So grab your piece of paper, grab your pen, and let's go. Welcome to MK's medical review series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. And today we're going to be looking at COVID-19 vaccines. If you haven't yet subscribed to the channel, please hit the subscribe button. Hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a like, drop a comment to start the discussion on COVID-19 vaccines. I will answer some questions at the end of this lecture, so please stay tuned and watch the video till the end. So before we actually go into details of looking at the COVID-19 vaccines, it's very important for you to actually understand the COVID-19 virology. Remember that viruses can either be of one of two types. They could either be RNA virus, which usually just replicate mostly in the cytoplasm of the cell, or they can be DNA viruses, which are going to embed their genetic material into the host's nucleus, and such that as the cell is dividing, the virus is also dividing with the cell. In addition to this, there is a special subset of viruses that possess an enzyme which is known as reverse transcriptase enzyme, which allows their RNA material to be changed to DNA material and be embedded in the nucleus of the host, like for example with HIV. So remember that COVID-19 or SARS-CoV-2, which is severe acute respiratory syndrome coronavirus 2. The reason why it's referred to as a coronavirus is because it has the spikes on its surface that actually give it an appearance like it's a crown. I've talked about coronavirus or COVID-19 in a very in-depth lecture. So if you want to check that out after you watch this video, you can click on this card here, as well as I will place it at the end of the video so that you can go and watch that video as well. So remember that the structure of this RNA virus is going to have, first of all, a membrane, okay, which has proteins. So there are membrane proteins that are present, which are known as M proteins. It also has an envelope, which is known as an envelope here, the gray thing here, and it also contains certain proteins that are known as envelope proteins or E proteins. On the surface of this coronavirus, you have special type of glycoproteins which are known as spike proteins or S proteins. Now remember, these spike proteins or S proteins are the ones that bind to the receptor, which is known as the angiotensin converting enzyme 2 receptor, that is present on cells that are found in the respiratory tract, and it is this protein that enables the initial steps such that the virus can gain access into the cell. So remember that the M protein that is present in the SARS-CoV-2 is actually 98% similar to the M protein that is present in a variant that was found in bats, and actually 98% similar to a variant that was found in pangolins, which are these creatures where it is believed that these viruses originated from. There's also 90% homology with the M proteins of SARS-CoV-2, and whereas there is some similarity of only about 38% with the M proteins of MERS-CoV-2 compared to the SARS-CoV-2, SARS-CoV-1 rather, and not SARS-CoV-2. Then, so here's a sketch that I want you to watch. I'll play the video twice. So the first time I'll watch it, you watch it without any sound because I removed the sound for copyright issues. So I just want you to watch this video, and this is exactly how viruses work, and then I'll explain through the video and talk you through the video about how viruses actually work. So just watch this video over here, and at the end I will explain exactly what is going on. Okay, so that's exactly how vaccines work. So let me just play the video once more, such that I will be explaining each and every single step and what's really happening so that you can follow the discussion very well. So this individual here is going to receive a vaccine. Okay, the vaccine may contain different things. It may contain part of a virus, it may contain a killed virus, or just parts of the membrane of a virus, or even parts of a protein that are present in the virus, or even the RNA that is present, or the DNA that is present in this virus. So it's going to be injected. So this is the whatever is supposedly gotten from the vaccine or from the virus and made into a vaccine is injected into the body. And remember that every foreign object that is injected into the body is pretty much going to be detected by the white blood cells. Okay, so this is going to be mimicking a situation that is similar to a patient actually getting the infection. So it's like this patient has gotten the infection. So that's why it's wearing this thing that appears like as if it's COVID, but it's not really COVID. Oh, sorry about that. I don't know why it's skipping. Okay, so it's wearing this to look like COVID, but it's not really COVID. And then it goes and stimulates the white blood cells. And then it's pretty much telling the white blood cells that I'm a virus, come attack me. So the immune system is eventually going to be alerted that there is this thing that's there, and it's eventually going to be destroyed. But once this virus is actually destroyed, the immune system is going to have an immunological memory. So this is the picture that's going to be given to these immune cells, such that whenever the immune system is going to be exposed to something similar to this, it's going to rather react aggressively to destroy it so that disease cannot be formed. I don't know why I keep skipping this. So let's get back to that. So it has given you formed what is known as immunological memory at this point, and the white blood cells now know that if we get something that looks like this, it's a virus. So the next time this individual that's vaccinated is now exposed to someone that's not vaccinated and they transmit the virus to them, then as the virus enters into the body, the immune system will now recognize that, okay, we had a pathogen that was similar to this, so let's start making more white blood cells, antibodies, and then that's how the virus is dealt with very quickly. And that's how vaccines work in a nutshell. I hope that actually explains how viruses work, or vaccines work rather, and so we can go on with the discussion. So getting back to our COVID-19 vaccines, remember that these are going to be providing an acquired type of immunity against the same severe acute respiratory syndrome coronavirus 2, which is known to cause COVID. And as of November 26th, there are about 7.88 billion doses of COVID-19 vaccines that actually have been administered worldwide based on the reports that we're getting from national public health agencies. And there are about 26 vaccines that are authorized for use by national governments, and of course 204 vaccines that are undergoing clinical trials currently that have not yet been authorized. So there are two types of vaccinations that you can actually undertake. There's what is known as active immunization and as well as passive immunization. So with active immunization, you're going to be injecting an individual with either live vaccines or non-live vaccines in order for you to actually stimulate the immune system and create an immunological memory of whatever has been attacking this individual. So this is obviously going to be the live attenuated vaccines are going to be the virus itself that has been weakened to some extent. So this is obviously going to be conferring a longer term of immunity. Examples of these live vaccines include things like oral polio vaccine, varicella zoster vaccine, measles vaccine, rubella vaccines. And these carry the risk of actually you developing the disease if, for example, you're immunocompromised. So they are given with caution, or if the patient is actually symptomatic, they're not really given in immunocompromised individuals. Then the non-live vaccines usually confer a short-term memory, so these actually often require booster doses, so including things like diphtheria, tetanus, pertussis, hepatitis A, B, injected polio vaccine, Haemophilus influenza type B, pneumococcal vaccines, as well as meningococcal vaccines. So the live attenuated vaccine should be avoided in patients that have immunocompromised, like for example patients that have HIV, patients with cancer, patients with congenital immunodeficiency, or even any other drug induced immunodeficiency. And then on the other end of the spectrum, you have passive immunization, where you're just giving antibodies. You're not really causing the immune system to be stimulated like with the vaccination, so you're just giving these antibodies. Now these antibodies that are given can be given, for example, against hepatitis B in babies that are born to mothers that are hepatitis B positive. So the types of vaccines that are actually present, you can have inactivated vaccines, you can have live attenuated vaccines, you can have messenger RNA vaccines, you could also have subunit, recombinant polysaccharide, and conjugate vaccines. So with the inactivated vaccines, you simply get a microorganism, the killed version of the microorganism, so it's inactivated. It can no longer cause any disease. So let's say if you want to get a vaccine against hepatitis A virus, you're going to get the hepatitis A virus and kill it, and then you are going to administer this such that they still will have those proteins that are essential to stimulate the immune system when they are injected into the body, such that now the immune system will still be able to recognize that this is a pathogen and I should make cells that attack this, such that you have this immunological memory. So this is done with hepatitis A vaccines, it's done with flu vaccines, it's done with polio vaccines, it's done with rabies. Then the second type of vaccine is known as a live attenuated vaccine. These are actually going to be containing weakened or attenuated microorganisms that have the propensity to actually cause disease. These ones, the advantage of this is that they're going to be conferring a much stronger and long-lasting immunity as compared to the inactivated vaccines. The inactivated vaccines often require booster doses, and they do not confirm a long-term type of immunity. The immunity is usually short. The memory is usually short-lasting. So examples of live attenuated vaccines include measles, mumps, and rubella, MMR, as well as smallpox, rotavirus, and yellow fever. Then another type of vaccine that has actually been researched for recently, and a lot of funding has actually been put into these type of vaccines, are the messenger RNA type of vaccines. This is where you actually insert or you isolate a type of RNA, which is known as messenger RNA, and this messenger RNA is injected into the body such that now it will stimulate the production of certain proteins in the body, and these proteins which this mRNA is going to stimulate are going to trigger the immune system, and of course trigger it to now start producing antibodies and memory cells against whatever you have injected it with. Then of course this immunity is also much the manufacturing times, or the time it takes for you to manufacture the vaccines as compared to the other types of vaccines, is actually much shorter. And of course, the virus isn't alive, so even the propensity of causing the vaccine-associated disease is much less. Actually, it's almost close to zero. Then this is actually done with some of the COVID-19 vaccines, which we will talk about. Then the last type of vaccines are either subunit, recombinant polysaccharide, and conjugate vaccines. This is where you use part of the microorganism, such as the proteins. Remember that S protein that I talked about the coronavirus on the previous slides? So you can take that S protein and actually just inject the S protein. So the body will treat that S protein like it's a COVID virus, such that now every time whatever enters into the body that has an S protein is going to be destroyed. Or you can use sugars or even capsids that are the capsid that is present in the virus. This is done with hepatitis B. It's done with human papilloma virus. It's done with pneumococcal vaccines. It's also done with meningococcal vaccines. The disadvantage of this is that they are very specific to specific strains. If the protein is not found on if the protein is not found on this virus, it will mean that regardless of you getting the vaccine or not, you won't be protected against different strains. You won't be protected against different viruses. Then we'll now come to the COVID vaccines. Remember that most of the vaccines that are under clinical trials, most of the vaccines that are on the market are just going to be focusing on the coronavirus spike protein and the variants of this as a primary agent for COVID-19 infection. Because remember that for the virus to actually gain access into the body, it needs these spike proteins to actually attach to the angiotensin converting enzyme type 2 receptors so that it can enter into the host cell and of course trigger this replication cycle. And then the S proteins actually can trigger a strong B cell as well as T cell immune response. The B cells and T cells are just pretty much white blood cells. And you also have other coronavirus proteins that are being studied, such as the nucleocapsid proteins, but we still do not have any vaccines on the market against these, and they're not so as effective. So they are three different modalities in which we could actually formulate hypothetical vaccines from. So we can either use the mRNA sequence that is present on the RNA sequence that is present on the COVID-19 virus. Remember that we have studied some of the genome or some of the genes that are contained in this virus, so we can actually synthesize an mRNA that we can actually make in a vaccine. So once we synthesize this mRNA, it's self-replicating, meaning that once it's ingested, or rather injected into the body, it's going to code for these viral proteins that are going to be synthesized into the host body. Then the body will start making antibodies against the coronavirus, such that if they get infected with the coronavirus, then they can quickly make those antibodies and prevent the infection. Another possible way is using the surface proteins, the spike proteins, where we can actually use recombinant technologies, where we can take part of this surface protein and then inject it into the body. And then once injected into the body, it can formulate antibodies against the coronavirus. The third possibility is that we can take part of the virus, we can take the genome of the virus and actually put it in another harmless virus. So we can use a vector, kind of like a car. So once this vector carries this virus into the human body, it's not going to replicate in the human body. The human body is just going to be detecting it as viral. And once this virus actually is detected as a foreign, rather, the human body is going to be producing antibodies against it, and then that's how you're going to have this immunity against it. So these are the three possible modalities in which the different types of vaccines for COVID-19 could possibly be generated from. So the main vaccines against COVID that are present include mRNA vaccines, which are being used worldwide, adenovirus vector vaccines, which are largely used also in different countries. And then, of course, we have inactivated virus vaccines. We also have subunit vaccines. So we'll start with the mRNA vaccine. So there are two important vaccines, the Pfizer vaccine as well as the Moderna. So both vaccines actually require 2 initial primary doses given at 21 days apart. So you get your first dose on day 0 or day 1, and then 21 days later you get your second dose. In some individuals that are immunocompromised, they should also get another dose after 28 days of the first 2 doses, and then they should also get another dose at least 6 months after the second, the 2 primary doses. And of course, how these viruses work, when you introduce this mRNA, so they're made up of mRNA, and this mRNA is actually self-replicating. What do I mean? Once you give this RNA in the human body, it will find its way into the cytoplasm, start replicating, and then eventually synthesize specific types of proteins. These proteins are going to be expressed on the cells in the body, and that's how the immune system gets to learn that there's something foreign in the body, and you start making immunological cells, you start making antibodies against this. Okay, so you're going to be introducing this into the human tissue, and the vaccine is going to either be self-replicating vaccine or mRNA, such that it's going to lead to cells in the body. Your cells are going to start expressing the same spike proteins that are present on the coronavirus, such that the immune system is going to be identifying this and will be able to identify any other further COVID-19 pathogens that enter into the body. Now, these RNA vaccines are often, but not always, nucleoside modified messenger RNAs. They have some side effects, but most of them are pretty safe. The major side effect that it has been reported, of course, are severe allergic reactions. In some rare cases, there has been anaphylaxis, where an individual reacts to the virus, their blood pressures drop, the blood vessels begin to dilate, their airways may swell up, they may close up, and they may have difficulties in breathing, and in some cases, they may actually even die. Then there are some concerns that have actually been raised, especially with this type of vaccines. So the main concern that actually has been raised is that if you give this RNA vaccine and it's replicating itself, what guarantee do you have that it won't actually invade itself into the host genome and actually cause other problems when it's in the host genome, or create a whole new virus to begin with? So what we know, what science says, is that RNA generally doesn't stay so long in the body. So it has a short life in the body. And with the RNAs, usually they do not reach the nucleus, so there is no risk of actually this RNA being embedded in the nucleus of this cell. So most of it is kept into the cytoplasm, or all of it is actually limited to the cytoplasm and doesn't reach the nucleus. So there is that concern on the general public, and that's why people have been shunning away from these mRNA vaccines, because of the possibility of them thinking that it can actually change the genes, it can embed itself in the DNA and change the genetic material. Then moving on to the adenovector viruses, or vaccines rather, I don't know why I say viruses all the time. Then examples include the Oxford AstraZeneca, which is present currently in our setup, the Sputnik 5 COVID-19 vaccine, the Janssen COVID-19, or the Johnson COVID-19, which is also present in our setup. Then you also have that one there that I will not attempt to pronounce. So the dose of the Johnson and the one that I will not attempt to pronounce are actually as given as single shots. Then the Sputnik 5 as well as the AstraZeneca require at least 2 doses. Then these vaccines are not going to be self-replicating. So they are not like the mRNA vaccines that enter into the body and start replicating and making proteins. No, these are the ones that are just put into a vector. They are put into another virus. Part of the coronavirus is actually inserted into the adenovirus shell. So you have an adenovirus shell, which is going to act like a motor vehicle. Then you're going to add this part of the DNA, or rather genetic material from the COVID-19. So it's going to be containing DNA that's going to be encoding for the SARS-CoV-2 protein, pretty much the spike protein. Then, of course, the difference is that these viruses are not going to be replicating when you inject them into the body, but they're going to just be present, and the immune system is going to be detecting them and making antibodies and immunological cells and immunological memory against this vaccine. Now, the big drawback about these type of vaccines is that they have been reported to actually cause many cases of thrombotic events where individuals formed blood clots that eventually led to serious things like cerebrovascular strokes or cerebrovascular accidents, which is also referred to as a stroke, pulmonary embolism, where you find a blood clot that is blocking the lungs and causing the lungs to die, part of the lungs to die. And also even these blood clots can be found even in the lower limbs, a condition that we refer to as a deep vein thrombosis. Then moving on to the next type of vaccines, you have the inactivated virus vaccines. Example is the CoronaVac, which is a Chinese type of vaccine, and the Covaxin, which is obviously an Indian type. So these are going to be containing viral particles that have been grown in culture medias, and then they are killed. So the viruses have been grown and they are killed, and they're killed using either heat or formaldehyde, and so that the virus loses its capability to produce any disease, but it will still be able to stimulate the immune response because it will still have those antigens that can stimulate the immune system. Though not as effective as the other types of viruses or other vaccines that we talked about earlier on, but they still do potentially cover you to some extent. Then you have the subunit vaccines, which are, for example, the peptide vaccine EpiVac Corona. So this is going to be having one or more antigens that are going to be introduced into the body without introducing the actual pathogen. So here you're going to be getting parts of the coronavirus. Now, there was one vaccine that was undergoing certain clinical trials, which is known as a V451 vaccine, and it was actually terminated. Reason being, they found out that patients that actually received this vaccine, they had incorrect. It started to affect the HIV results that were taken after the vaccine was actually given. So these were terminated, and generally they're not as effective as the other vaccines that we're using currently. Now let's talk about effectiveness of the vaccines. How effective are they? So the COVID-19 vaccines are actually highly protective against severe illness. They will not protect you against getting the infection. They may reduce the chance of you getting the infection because your immune system will be alert to clear out the infection as quickly as possible, but they do not protect you 100% from getting the infection, which is why we get these cases where an individual may have gotten the COVID-19 vaccine, but they still have COVID-19. So the vaccine does not protect you 100% from contracting the disease. But if you do contract the disease, then it's going to be less severe. Even the hospitalization and the deaths that are related to COVID-19 are much less. And according to the CDC, they actually estimate that the unvaccinated people were 5 times more likely to be infected, 10 times more likely to be hospitalized and 11 times more likely to die. So this already goes to show you that the vaccination program is actually much more effective than we thought it would be, even though we're not yet at our target where we need to be. So according to the CDC, they further go on to say that actually the vaccine effectiveness reduced from the alpha variant that we had of the coronavirus to the delta variant. Every time remember that viruses have mutations. Mutations change the virus in a way. It could be that it changes the structure of a certain protein, like for example, the spike protein, or part of the spike protein may change, part of the envelope proteins may change. And whenever these change, even the immune system gets confused. It's kind of like you have a door at your place and then someone comes and changes the lock and puts something similar to your key. Your key will enter, but it won't be able to open the lock. So because it has changed. Same thing with the viruses. Once the viruses mutate and change to some extent, the effectiveness of the vaccine also reduces. So from the first mutations that had an effectiveness of 91% coverage to about 66% with the Delta variant, which is the last predominant virus before the one that was recently discovered in South Africa. So as we can see, as we're moving further with the mutations, the effectiveness of the vaccines is dropping. But note how the effectiveness is not has not dropped to zero. Despite these mutations, we still have some coverage from the vaccination. So some side effects before we move any further. So you have to take note that all vaccines that are given intramuscularly, be it COVID vaccines, be it any other vaccines of any other disease, are going to have some side effects. The side effects may be related to some mild trauma that's going to be associated with the procedure because you're just injecting and you're causing damage to the skin. And you could also have the introduction of a foreign substance in the body that will cause a reaction. So the area may be sore, it may be red, there may be some rash, there may even be some inflammation at the site of injury. Other common side effects include fatigue, headaches, muscle pains, which we refer to as myalgias, joint pains that are referred to as arthralgia, and generally these are going to be resolving within a few days. There has been some severe side effects that have been actually pointed out. Anaphylaxis, like I already explained to you, where you get these features where you react to the virus, your blood pressure may drop, your blood vessels may dilate, your airways may begin to swell up, they may actually close, and you may have difficulties in breathing. Then, of course, with the Johnson & Johnson and AstraZeneca, there is an increased risk of thrombotic events, like I already told you, but this increased risk is not really seen with the other types of mRNA COVID-19 vaccines, like the Pfizer and the Moderna. Then let's talk about the new strain, which is the Omicron strain. So remember this was referred to as the B11529 variant that was first discovered in South Africa on the 24th of November, 2021. So the first confirmed case from a specimen that was collected was actually found on the 9th of November. And a virologist actually from the University of Warwick named Lawrence Young actually described the Omicron variant as actually the most heavily mutated version of the virus that we have actually ever seen. And why is this so? Because there has been over 20, some literature even citing over 30 different mutations that have actually been seen. And this is how it works. These viruses are usually named giving the Greek alphabets: alpha, beta, gamma, delta, so on and so forth. So the beta delta had about 3 mutations. The delta variant had about 2 mutations. So in comparison to these beta as well as the delta, we have actually noted that the Omicron variant actually has twice as many mutations as compared to the Delta variant, which was really devastating because it originated in India, and that was what is responsible for the second wave. So what's also very concerning about this new strain is that the COVID-19 vaccines are going to be based on the coronavirus spike protein, the S protein that I talked about. So if there are changes in this protein, and we have actually noted changes in this protein, it would mean that our vaccines are going to be reducing in effectivity. Take note how we are saying that they are going to be reducing in effectivity rather, and not really completely ineffective. So there will still be some coverage, but it will be significantly less. With the actual values and the actual percentages, those are still in research and studies are still being done currently as we speak, but there will be significantly reduced coverage with the vaccines. So despite this new strain coming up, we still are encouraging people to get vaccinated and to still get the vaccine. And any new variant that is actually able to evade the vaccines or spread much faster than the dominant Delta virus is actually going to be a significant threat and may actually worsen the pandemic that we're already in. So you still can get vaccinated despite the Omicron variant. Then there are some questions that I want you to leave on your mind in order for you to start the discussion in the comment section below. Please note down your concerns concerning the virus. Give me your views on whether you should get the virus or you shouldn't get the vaccine, rather, whether you should get the vaccine or you shouldn't get the vaccine. And let's start the discussion below and share this video to someone who is a believer for the vaccine, even to someone who isn't a believer for the vaccine, so that we get both sides of the coin. So the first question on our frequently asked questions is, what's the difference between the immunity you develop from getting the COVID-19 and the immunity you get from COVID-19 vaccine? So you get those individuals that say, I've already had the virus before, why should I get the vaccine now? So here's the thing. People react differently to different things. So when they get a virus, the immunity that they're going to produce against that virus is unpredictable. We do not know so much about the COVID-19 virus. It's still evolving and we're still learning a lot. But what we know is that with the virus itself, individuals may react differently. Some people may confer a much stronger immunity against the strain that they got. Some people may not confer a much stronger immunity against the virus that they contract. That's through the natural ways. But with the COVID-19 vaccines, we can actually predict and we can actually forecast how well someone is going to respond or how effective. They'll give you a percentage of how effective this vaccine is going to be or how effective it's going to stimulate the immune system. So which is why, despite individuals getting the virus, they should still get the vaccine. So which leads to the second question. Can I still get the vaccine after getting COVID? So you still can get the vaccine after getting COVID. Just check with your general practitioner, but generally the rule of thumb is you should wait at least 90 days after you have been cleared free of the disease. So at least 3 months after you've been cleared for the disease, that's how long you should actually wait. And should vaccination be mandatory, which is the biggest question that everyone is asking, because there have been some regulations that have been put out, and the discussion here is about protection of individuals, because it's not just a simple individual or one individual or the whole nation versus autonomy of the patient. And I'm speaking from a scientific point of view or as a doctor, and I feel that, or rather, not even I feel, it is supposed to be that each and every individual's patient's rights must be respected and autonomy must be respected, and you have indeed the right to choose whether you refuse to get the vaccine or get the vaccine. But once you refuse to do that, at least make sure that you're not putting another individual at risk. Make sure that you're not putting your friends at risk. Make sure that you're not putting your family at risk. And it's understandable where you can actually institute these strict parameters to curb the spread of the virus. So let's start the discussion below and give me your points of whether it should be mandatory or whether it shouldn't be mandatory, and the regulations that have been imposed on different countries. Should we be following those or shouldn't we? Are they an infringement on autonomy of patients' rights or the right to choose or refuse treatment, or are they not? Please let me know in the comment section below. Thank you for spending your time to listen to this lecture video, and I hope you really enjoyed learning about the COVID-19 vaccines. If you did, hit the subscribe button and also check out the other videos. Do not forget to also check out the COVID-19 video that I will leave at the end. Thank you for spending your time to listen to this. My name is Dr. Moses Kazevu. This was MK's